This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
Hello, everyone, and welcome to another episode of the 1 Million Lives podcast. For those in the north, I hope you all had a lovely summer. And for those in the south, I hope your winter has been equally nice and that spring will soon be there for you. My name is Michael Sauter. I'm the Chief Learning Officer at Laerdal Medical and your humble host in this episode. So here in Norway, we had a rather rainy summer, at least here on the west coast where I sit. So I have had plenty of opportunity to sit in meditation mode under a roof or inside with the calming sound of rain as the backdrop. And one of the areas of my reflection has been how tough it must be to be a healthcare provider and healthcare worker in these times. On one side, you came to the profession to make a positive difference. Most healthcare providers are genuinely driven by providing the best possible care and treatment. On the other side, you know that mistakes you and your team may make can have a potentially fatal consequence for the same patients that you care for. And as we have learned over the last few years, media is more than interested in publishing some of these stories, often leaving out some of the nuances needed for us to get the full picture, or what they do is finger-pointing to individuals when, more often than not, the problem is systemic by nature. And in this intersection of patients and their families, the standardizations of protocols and procedures, and the all too fallible humans doing their very best to deliver high-quality care, there seems to be a tremendous opportunity for what has become known as healthcare simulation, both for the purpose of training, but perhaps equally much to drive positive change on the system level with regards to patient safety and improved outcomes. In today's episode, we will meet someone uniquely positioned to talk about these matters. I've known him for the better part of 15 years, and I deeply respect his knowledge, practical experience, and vision on how to improve patient safety by the way of using healthcare simulation in different forms and fashion. In the global community of healthcare simulation, Dr. Paul Phrampus would need no further introduction. From the base, as director of the Wiser Simulation Center in Pittsburgh, he's been a global leader and visionary in this field for the last 2 decades. In this particular talk with Paul, we agreed that the timing was good to discuss how simulation can play a crucial role in improving patient safety. Typically, healthcare simulation has this big education or training sign dangling over it. And while that may be the widest base of adoption of simulation, it also has the potential to play this crucial and life-saving role inside our healthcare institutions in situations where the main focus may not be primarily be learning or training, but rather improving the way we work, the processes, the procedures, with the goal of improving patient safety and outcomes. So without further ado, I will get right out of the way and leave you with the discussion I had with Dr. Paul Phrampus on the topic of opportunities and potential pitfalls in using simulation to improve patient safety. Enjoy. Welcome to our 1 Million Lives podcast, Paul.
Thanks, Michael. It's good to see you. I always enjoy our time together.
Definitely. And I've actually said in the intro that you and your work at Wiser Simulation Center is well known to a global community within simulation. But I think there might be listeners out there who still could benefit from getting to know you a little bit better. So perhaps you could sort of tell us a little bit about your background, how you came to the field of simulation, and so on.
Oh my, that could be a whole podcast by itself. But the short story is I had a rather circuitous route to simulation and also to medicine. Actually, a long time ago, I was a volunteer EMT turned paramedic, then put that aside. When I graduated from high school, I went in the Navy for 7 years, and I was an electronics technician in the United States Navy. I worked on radars and computer systems, and during that time, developed a penchant for teaching others. And it just kind of evolved along that way. When I was finishing my tour of the Navy, I decided, wow, I should probably go to college to advance my chances in life and so on. So I transitioned to, I was still volunteering and working as a paramedic, and I got into the medical pathway and decided to go to medical school to be an emergency physician. And I kept that training piece to my life. And then when I ended up in Pittsburgh for residency, the training and the technology geek stuff that I got from being an electronics technician and teaching all kind of culminated with this magical thing called simulation. And I was introduced to my former mentor, John Schaefer, who was one of the creators of airway products that are still in the SimMan to this day. And I was like, wow, education, medicine, technology, all in one room. And that was really how it happened.
Yeah, and it's fascinating. I mean, I've also had the great pleasure of working with John, and I think he has something to teach everyone. He's a true visionary and certainly helped me understand the depths of some of these issues we're talking about. Now, today, I wanted to sort of flip the view a little bit, and I've already said that today's topic is going to be around something that has emerged more recently, and which is perhaps in a more oversimplified way could be described as what is simulation and what does it look like when it's not necessarily done for training or upskilling alone. And I think it would be good to put some parameters around that. So maybe you could fly us in over these areas, maybe on a high level, fly us in over healthcare simulation first, and then fly us over to patient safety and tell us what you're seeing there.
Yeah, I have a unique vantage point. My role today, as it's evolved over the last 25 years at UPMC and the University of Pittsburgh, allows me to not only direct the simulation center and have been able to grow that over the years, but I also have a formal role as the medical director in patient safety for our health system, which comprises 40 hospitals, and it's a big enterprise with 96,000 employees and on and on. So I kind of get a view from both sides of the coin. When I think of healthcare simulation and where we've come traditionally in the last 20 years, a lot of it has focused on the training and education of individuals as well as teams. And I think that now looking at simulation from a leadership perspective, at the global level, I think it really divides into two camps, two tribes, depending on how you want to look at it. And one group is those that are teaching people who are in school to become a healthcare provider, and then those that are working on simulation and using the methodology on the practice side in the hospitals and the healthcare systems and the outpatient clinics, and how we look at simulation. There's a lot of overlap, obviously, but then there's some core differences. And I think that when we think about healthcare simulation in general, we still think of the mantra of people around a high technology simulator or perhaps a task trainer getting graded on what they do to make sure that they are competent. And then we start to diverge into what the intended outcomes of that are. And if you're on the student or school camp, which we have a great relationship with and do a lot of work at the University of Pittsburgh with our School of Medicine, our School of Pharmacy, and our School of Nursing, and their primary aim is to raise knowledge, develop skills, and be able to demonstrate the application of knowledge and skills at the level that is set forth by the accreditation requirements to graduate in your respective field, whether that be a medical student becoming a physician, nursing student becoming a nurse, pharmacy student becoming a pharmacist. So a lot of the attention is on the development of knowledge and competencies to meet those accreditation requirements. When we shift over to the use of simulation for the patient safety side of things, it's still, I'd say, the wild, wild west. And I like to think of it as a rather underdeveloped part of what the simulation community can bring to the healthcare system globally from a quality and patient safety perspective. I think that the key is figuring out what aspects and elements of the simulation methodology can really drive things forward to improve quality and improve patient safety. And what it causes is a little bit of uncomfortableness in those that think of simulation as primarily a teaching tool to teach students how to graduate. And I think that a lot of the work in the simulation community, our own included, for many, many years, has focused on the honing of the pedagogy to make sure that we do it the best that we can. We're still trying to develop evidence and best practices and those kinds of things. But my point is that the focus has been on just the education honing and not the actual application and generating the intended outcomes. And when we shift to patient safety, there's a lot of competing interests when you get inside of a hospital or inside of a clinic for investment, for time, for the needs for education and so on. And we have to think about things a little bit differently than just getting students through school to be able to graduate and become competent.
Now, if we take it down on a very practical level, and it may be me putting up a straw man or a false dichotomy, but for the individual or the team, and maybe even on the system level, how does simulation look different, walk different, if you choose to do it for education or if you choose to do it for patient safety?
Well, I think that there's a lot of things to think about. One is your mission. As you know, and I know that without a good mission and vision, things kind of quickly get frayed around the edges in terms of determining success for outcomes. Once you have that mission and vision established that includes patient safety, I think then it's your programmatic lineup. You can't take, a lot of centers try to take their cache of courses that they use, let's say for the medical students or for the nursing students or whatever, and just move it over to the hospital or healthcare system side of things. And it doesn't work. The same thought process of a needs analysis for the educational needs to be thought about in terms of the practicing healthcare environment. What are the needs? They're different than what schools experience. And I think that we have to have that fundamental difference. And as I was saying earlier, that when we predicate all of our work on what students need, we find at an analytical level, when you look back, that's not what practicing professionals needs. More importantly, that might not be what your hospital needs or what your clinic needs. And those needs can be different. So if you think about the focus on education, you think about the safe learning environment and the significant amount of time and effort that is devoted to debriefing, that is because those things are centrally core to the education process. Okay. When we move over into the healthcare side of the equation, there are other things that become core, like identification of latent patient safety threats, for example. That might be the core reason we're doing the simulation. We might not even offer education during the simulation, or maybe we'll offer a smattering of education associated with it, because there are operational realities on the providing of simulation services that kind of, you can't be all things to all people. And that's what happens. So what I'm trying to say in summary, with a long answer to your question, is that I think it's about focus. It's about focus and understanding, comparing and contrasting your work, if you're on the education side of the house, to what it transitions to when you're on the quality and patient safety side of the house in actual healthcare environments.
So let me then try to provoke this a bit, because there seems to be a notion among some that if you just train enough, then patient safety will somehow magically appear. And I guess to some degree, you will have an impact on patient safety. But what do you think about that sort of leap of faith you're doing? If you put all your efforts into training, then that will impact safety.
Well, that's a whole nother can of worms by itself, Michael. I appreciate the question. One is, I'll tell you that within the world of patient safety, we struggle with the same exact things, separate from simulation. And in fact, we do incident analysis, we do root cause analysis, we do failure mode effect analysis, all these tools in the patient safety world. And we end up coming back to saying, we need to educate, we need to educate, we need to educate. So I think that it is tough to say train away patient safety. I think that we need to figure out, when does education and training make sense? And then once we establish that it makes sense to fix a particular problem or raise quality in a particular area, then we need to figure out what the methodology of education that makes most sense. If we're talking about a simple policy and procedural change, perhaps, maybe we don't need simulation. And if we're talking in online education or emails or good old fashioned, paper, might do the trick. I think that when we continue to try to bring stimulation into it, and we're using stimulation in a way that's not efficient and not effective, that's kind of how it gets a bad rap around the C-suite of the healthcare system. And I think that we need to continuously analyze and reanalyze those things. I think that part of the issue is, especially for the education community to understand, is patient safety is a complicated, very local problem to each and every institution, every clinic, every system, every hospital that has their own needs associated with patient safety. And by making people smarter, making people work harder, improving their teamwork and communications just as a blanket attempt at education isn't going to fix much. We need to dig into the policies, the processes, the procedures, and figure out, what are the best things that we can do and address the local problems that exist at this particular institution. And then once we identify those problems, then we can say, now let's look at some of the solutions. And some of the solutions will include education. Some of the education will obviously be perfect for simulation.
I'm going to put a pin in that, what you said about local. I think that's quite central to where we want to get at during the conversation. I read an editorial article you wrote back in 2018. This has been on your mind for quite a long time, I know. And there you used the term deep integration. For simulation to be successful in patient care, there needs to be deep integration. Could you unpack that a bit?
Yeah, part of that, I'll give some credit to David Gaba on this one, actually. He wrote, I believe it was an editorial or a concept piece or something long time ago. I think it was 2006, 2007, something like that. And he basically made a statement in there that said, for simulation to be successful in patient safety in practice, that there has to be a significant amount of resource alignment associated with it. I'm paraphrasing. I don't have it in front of me. But it inspired me to think, and then as my role evolved in this kind of split personality of sim center director and safety leader, I started to realize and talk to some of my colleagues around the country, around the world, and find out, and this goes back to that education versus healthcare system side of simulation. Very few simulation centers or very few simulation programs around the world have direct access to a relationship within the C-suite of their hospital or health system with people that lead quality, people that lead risk management, people that lead patient safety, people that lead personnel operations, whether we're talking about nursing operations or physician operations, and then even the finance teams. And I think that what we need to establish, and what I've been calling for the last few years and kind of prompting people to do, is to create those relationships and get a seat at the table so that the simulation community can better understand the deeper needs of the hospital or healthcare system.
So, but that begs a question, Paul, and as I hear you talk, it strikes me, there's another question that's sort of rising on the horizon here for me, and that is, as you know the community, and few people I know of know this community better than you, how well equipped, how well prepared is this community to have those relationships, have those discussions, and see themselves as being a tool in that machinery?
I think that so I've been thinking a lot about this. I've been working with some colleagues around the country, and we're working on a publication to propose an integration strategy, and how to look at it, and what are those relationships? How do they exist? How do they form? How do they mature over time? And I think that a lot of stimulation programs, I agree with you, are probably not equipped to do that. Many people are strained in terms of time and resources as it is now. But let's just say we can move beyond that. I think that it's really important that stimulation professionals bring an honest appraisal of what they are capable of and not capable of. What is common core stimulation? What is stretch stimulation, if you will, to make a difference? And where I see a lot of failed attempts at the establishment of these relationships is the stimulation person comes to the table and says, we can do this and we can do this and we can do this, and kind of push upon them what is successful in that particular simulation program or center. And I think what needs to happen is it needs to start with a listening tour. Somebody from the management leadership structure of the simulation program needs to have a regular seat at the table, not only be involved transactionally when there's a simulation thing that might come down the table, but understand the vocabulary, the vernacular, and the inner workings of the safety and quality machine at their institution, so that then they can be thought of as a trusted partner in solving the institution's quality and safety program, as opposed to a vantage point of being the simulation champion for their institution or program. Once we go to try to solve institutional problems, institutional level problems, then we are going to raise the bar of return on investment for simulation.
And I want to actually follow that a little bit deeper. So I'm running a sim center in our hospital, and I now feel mature enough, ready enough, and we have capacity to be of service for more in the hospital. What are some logical steps, generally speaking, if at all possible, that I should take to be seen as a valuable partner in this?
Yeah, I think that getting a seat at the table, and I mean that just kind of literally, and getting involved in patient safety committees, getting involved in incident review processes, getting involved with safety review committees, so that you understand the totality of the problem of your institution is the most logical first step. I think also that another logical first step is to invite the leaders of the institution to come to the simulation center for a meeting, for a private tour, and so on. And I know this has been a tactic for many, many, many years, but and still continues to this day, by the way. And I think it's very important. In fact, I recently had our chief financial officer at Weiser and had her intubate a patient. And so it's still an important part of advocacy within inside of your institution. But back to your pathway. So you sit at the table, you bring recommendations, you understand what your institution is up against. You have the leaders of your institution visit your simulation center, but we have to be very careful that it's choreographed in a way that their visit needs to align with solving the problems they face. They don't want to hear about better education, happier providers, etc., even though these are all very, very important things. They're thinking about, how do I decrease my bloodborne pathogen problem with central lines? How do I decrease ventilator-associated pneumonia? How do I decrease my unanticipated hospital mortality rate? And that stimulation center visit needs to kind of be crafted to focus on things that are going to solve the institutional problem. And then I think that is how you begin the entree into understanding how you can bring more value to the institution that provides you, the financial wherewithal or the stakeholders in your operation to continue your success.
And obviously, you speak from experience. You have gone this path with Wiser and your team colleagues there. Any other potential pitfalls there? I mean, you mentioned don't come dragging your education hat. That big sign with education on it. Don't think you have the answer only. Any other things where I could step wrongly here?
Well, I think that you just kind of paraphrased a lot of them. I'm an educator at heart. There's no doubt about that. But I can tell you that inside the walls of the practicing hospitals and health systems that are emerging today, the education group has very little power. And that's pretty universal in my travels around the world. You're trying to line up much more with quality, safety, risk management, because that is mostly aligned with the financial engine, which is the power of your given institution. And this sounds a little bit curt when we're talking about lives and healthcare, but it is a reality that we all need to face, and it's an operational piece that we need to move forward. So I think that as we move along, and you're saying pitfalls in an integration model, one of the things I'd be very careful is that you continue hopefully a strategy of under-promising and over-delivery. And what I mean by that is once you're exposed to this world that you didn't even know existed inside your institution called quality, safety, risk, and you see all the data, you'll suddenly be flooded with new ideas on what we can do and how we can do it and so on. And I think that it's very tempting to again try to be all things to all people or all things to all problems. And what you'll find is your institution is struggling with a whole lot more things than you actually thought. You need to make sure that you get the internal priorities lined up and then start attacking them in the order and veracity by which you are staffed and you have the resources to make a successful impact.
Insightful. And I want to speak to you a little bit, shift gears a bit and speak a little bit to your tech gene. As you mentioned in the beginning, you have one. And I know from our talks previously and my visits to Wiser, this is very much prominent. And I actually like that a lot. Someone like you who is a visionary in this domain and a practitioner and recognized as such, but you're also able to speak to technology. And that brings me to, is there a role for technology in this? And what does that look like?
The primary currency of technology, this will be an unsatisfying answer to the broader simulation community. The primary currency of technology for the discussions that we're having today, meaning how do we integrate further into patient safety, is information technology, and it is gaining access to information systems. It is creating information systems that allow you as a simulation program to generate meaningful data to contribute back to the information that your hospital or healthcare system is struggling with. And I think that is a huge part of what needs to happen within the simulation community. Now, that being said, understand, Michael, you know me well. I am a technology geek. I love all new things coming down the pike with AR and VR and so on and so forth. But I do think that a part of our success at Wiser, honestly, without trying to sound like a self-serving advertisement, is part of our simulation information management system and the way we collect data and the way that we're able to parse that data and create the reports that the health system finds beneficial. And it's not always the reports that you think it is. And again, most simulation centers are going to say, yeah, we trained 1,000 people and they loved the training. The C-suite it's not that they don't care about the healthcare workforce loving the training. They are already having the assumption that they are giving your program money to exist. You are putting on great training. The data has to take it another step forward. But to generate useful data, you have to generate useful programs. And those useful programs come from helping to analyze and synthesize the data that is in the quality and safety world of your institution. So that's where I think technology is gaining access to information that simulation centers don't routinely have access to. Then as we move forward with technology, I think obviously things that simplify the simulation process in terms of being able to generate reports of who did what, how well the training occurred, and perhaps helping to model before and after looks at the data in let's say a given unit. If you start a new training-based initiative that involves a simulation, how are we tracking that data and following it to make sure that we're making an impact? So I think it's mostly information technology, but as new technology comes forward to support the simulated and immersive learning environment, of course, we want to embrace those that make sense as well.
And it reminds me the note we pinned a little while back, because you mentioned this very, I think, and you wrote about that in another article I saw, this need to stay local. And I'm sort of, we're coming towards an end here, but I wanted to understand your take on this. So how much can we push top down, and how much of this is bottom up in this approach where simulation is sort of trying to help to improve patient safety?
Well, I'd say that the easy answer is the simulation program would do well to find itself inside of an institution that has a top-down mandate for simulation, because they don't really exist. And we have been fortunate here at the University of Pittsburgh and the UPMC health system to have evolved to senior leaders that think of simulation as part and parcel to safety and quality. So we have that top-down initiative. The localization part that I was talking about before is engaging local providers, but also understanding local problems. Because if we go back to the underlying theme of what I've been talking about today, it is aligning with your particular hospital, your particular health system to understand the needs and challenges that they have. We have 40 acute care hospitals across our system. I can tell you, of course, I can tell you a couple of the problems that are on the top 3 or top 5 list of each of the hospitals, but then I can't tell you the next 3 because they are very local, even inside of a integrated healthcare system. There are practice differences or staffing differences or resource differences that exist that create unique problems that need to be solved in different, even amongst our own hospitals. It's a very local phenomenon. The other thing that you find is, and I just did a big presentation, and we're rolling out now our culture of safety data for our institution, where we had over 50,000 responses to our safety survey. Is local culture is embedded throughout the safety and quality process. And we can see, some hospitals of ours that safety is a concern, others where safety is flourishing. And how can simulation, how can those of us coming from the outside, if you think of the simulation center as the outside looking in, where do we fit in? How can we create solutions that help a system raise their quality, decrease their safety events, and increase the safe care that patients get wherever they are inside that health system?
And sort of we're rounding up here, Paul, but sort of on a final note, I'm curious as to what's next. What needs to happen now or in a few years to come for the simulation community at a larger scale to be of this kind of use that you're explaining now? And I guess a side note to that is, can the society play a role here? I mean, the accreditation program is terrific. Is there a role for this in the accreditation program, for instance?
I think the society addressed this a long time ago, and there were major revisions to the accreditation process when I was president, and part of that was rolling in the systems integration piece of accreditation and other aspects of it. And I think that laid a basic entree into how to start these relationships that we're talking about here. I think it's critically important, and I think that maturing that even to a bigger piece will be helpful to the simulation programs. And I think that it lays a framework of how those communications could and should occur. With regard to the society, I think the increasing advocacy around simulation from a patient safety perspective and patient safety tool is something that we've been working on for a long, long time, even back, since the inception of the society, really. But I do think that we need to have a think tank established that is thinking in terms of that tribe that is the people that are trying to advance simulation inside the walls of hospitals, because the outcomes, the design, the mission is quite different. And so I think that some attention around that sort of aspect will do well. The other thing I think is training of more senior leaders and really getting people to understand these differences that exist when we go and talk to the leaders of education versus when we go and talk to the chief quality officer or the chief finance officer, and how those conversations are a little bit different. They're not intuitive. They have to be planned. They have to be crafted. And I think the training of some of our senior leaders in simulation can help move things in that direction. And then the last thing, this is a little bit localized to the United States, because it's obviously where I know the politics and the regulations the best. But I'd have to say we got to start getting lobbying accomplished to get some more forceful attempts at getting simulation pushed into the healthcare system. And it could be occurring at the legislature, at the federal level. Some states have enacted some things, but it's pretty weak overall. And the other thing is regulatory bodies like the Joint Commission, like the CMS and other entities in the United States, I think need to understand that this happens. And again, if you think back, I know you were at my talk a couple of years ago at the IMSH, I talked about when the two eras human essay was published, the report to Congress from what was then called the Institute of Medicine in this country. Simulation was mentioned like 18 times as part of the solution. Yet here we are 23 years later, and we're at an impasse of how do we keep the drive and the momentum moving forward for all of patient safety, quite frankly. But also that simulation thing never matured. There was never a maturation that seeped into regulatory requirements, accreditation requirements, or federal mandates or laws that put simulation front and center. And I think that we need to revisit how did that happen? And then where do we go for the next decade to try to influence this to give simulation a little bit of a rocket boost in moving forward. But I will also say that the patient safety movement in general is starting to feel some of that pressure. I think some of it is because of the setbacks associated with the pandemic, the new challenges we're facing with the healthcare workforce. But a lot of us in the patient safety community are saying, we don't feel like we're making that much of a difference anymore. And how do we retool and how do we re-engineer so that we can? I personally think, obviously, this is could be self-serving or not. I don't know. But I personally think simulation has a lot to offer the answer to that question. But it's got to be crafted in creating solutions for institutional problems, not how do we wow people with better education.
And that's exactly what I take away from this talk, Paul. As always, very inspirational. And the fact that you just point this out so clearly, the need and also some of the solutions and the visions we should work by. I'm really, really grateful for this talk. Thank you so much for joining us on the 1 Million Lives podcast, and hope to see you again soon.
Thanks, Michael. I appreciate the invitation, and good to see you as always.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.